Good morning, everybody. We're a few minutes late, but I'm going to call this meeting of the El Paso County Public Health Board meeting to order. Okay, well, hopefully everybody on our, we've got 5 of our board members here this morning. I know that we've got a couple more en route. General Jack Briggs is an excused absence today. He is traveling with family. And I believe that we have Dr. Deborah Chan is online. And if I get a thumbs up from somebody. Do we have her? There she is. Can we see her? Okay. Let me start off with a member roll call. And I'm going to start with those that I know are present. Okay. Dr. Vu?
I'm here.
Commissioner Bremer?
Present.
And Doris Ralston?
Present.
And Commissioner Gonzalez?
Here.
Okay, and as I said, we've got a couple more en route. And Dr. Chan, I see you there. Can you give us a thumbs up?
Yes, I can hear you.
Okay, great. Hopefully you've had an opportunity to look over the agenda. I need a motion to approve and a second.
So moved.
Thank
Second.
you, Doris. And second from Commissioner Gonzalez. All in favor of approving the agenda as it's written, let it be known by saying aye.
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 Any opposed? And I didn't think so. Okay. And we're going to move on to Board of Health comments. I'm going to look on the dais here. Anyone have any comments they'd like to make? Commissioner Gonzalez.
Thank you, Mr. Chair. So just a couple of questions I know that comes up later in our regular updates because of a lot of questions going on around the county the last several weeks. I was just wondering if we could specifically mention any, if there are any upticks in what some might consider exotic diseases, whooping cough, TB, and measles, from what would traditionally not be people from the United States have been immunized on. Thank you.
Okay. Well, I think we're going to do it in the director's report. Thank you. Oh, I think Glenn is probably coming in the building, so. Any other comments from board members? Commissioner Bremer.
Thank you. Just very quickly, it is the very end of what's known as Heart Month for cardiovascular disease and awareness. And a lot of what we do at Public Health has to do with prevention. There are some diseases and conditions that are preventable, and cardiovascular disease is one of the most of those. So I would encourage people to not just pay attention to it in February, but pay attention to it year-round. February went fast this year, so.
Yeah. Very well said. Dr. Vu, any comments?
No comments. Thank you.
Okay. I think the only comment I would like to make is that earlier this month, I had the opportunity to go to the State of the Region address, and our very own Commissioner Bremer delivered really a wonderful speech that talked about our county, the wonderful place where we live, and the many, many positive things that are going on in our county. So well done, Commissioner Bremer. But really to everybody who works in and part of this county, well done. You're all taking great care of our citizens, and we're very grateful, very appreciative. Thank you. Okay, public comment. Do we have any public comment? I'm seeing negative head shake, so we don't have any public comment. I see the Councilman Dave Donaldson is making his way to the forum, so he'll be up here in just a moment. All right, that takes us to Finance and Budget Report. I'm sorry. I'm sorry? Oh, is that on there? Oh, I'm sorry. Just before you get started, we do need to approve their minutes. And I read right over that. Thank you, Doris. She always keeps me straight. So I need a motion and a second for the approval of the minutes. So moved. Thank you, Doris. And a second?
Second.
And Commissioner Bremer with the second. All in favor of approving the minutes as written, let it be known by saying aye.
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 And any opposed? Again, not hearing any. And thank you for being patient with me. We're ready for the finance and budget report.
Good morning. I'm Sarah Kinney from Financial Services, Budget Supervisor for Public Health. This morning before you, in your Board of Health packet, you were provided a resolution for your consideration to recognize revenue and appropriate expenditures in the amount of $168,000 for the Public Health Emergency Preparedness Grant that will support emergency preparedness and response in El Paso County. I'd like to explain a little bit about what that is for your consideration. The Office of Emergency Preparedness and Response is a core public health service as defined by 6 CCR 1014-7 and the Centers for Disease Control and Prevention, which provides public health emergency preparedness funding to states to strengthen public health's ability to respond to a range of public health threats. And the Public Health Emergency Preparedness Grant is an all-encompassing emergency preparedness contract with the Colorado Department of Public Health and Environment for the 2023-2024 year. The Emergency Preparedness Response Program has received $168,000 in extended authority funds from the Colorado Department of Public Health and Environment to be applied to the Public Health Emergency Preparedness Contract starting from July 1st, 2023 to June 30th, 2024. So these funds could be used for expenditures basically from those dates. The amount of $168,000 would be broken out in the following manner. Personnel expenses of $147,500 and program expenses estimated at $20,500. The indirect percentage on this grant allowed is 17.91%, and our previous contract amount was around $586,236. This falls under Division Director Deanne Ryberg, our Deputy Director. Our program manager for this program is Janelle McNair, the Emergency Preparedness Response Program Manager, and we've already been executing successfully under this program. Do you guys have any questions for me on this?
Go ahead, Doris.
So this grant ends the end of June. Is it likely that we'll receive another grant that would start July 1st of 2024, since this one goes from it ends 6/30/2024?
Well, it's difficult to make forward-looking statements. In the past, we have received other grants for emergency preparedness, so I'm optimistic, but I can't make any certain statements. I would have to defer to the program manager and division director who are here today as well if they'd like to make a comment.
Thank you.
Sarah. Deanne Ryberg, Deputy Director. This is supplemental to our typical emergency preparedness and response funding. So while this supplemental funding will terminate in June, we have seen repeated funding for this programmatic activity year over year and are part of a 5-year federal planning process to distribute funds to local public health agencies. So we do anticipate that funding under this category will continue.
Any other board questions from board members? Okay. Are we awaiting do we need to do a resolution here?
Yes, sir.
I'm looking over at Lori. Next steps. Sorry.
Move to approve the resolution to recognize revenue and appropriate funding for the Public Health Emergency Preparedness Grant.
Okay. So Commissioner Gonzalez made the motion and Doris Ralston did the second. All in favor of approving the acceptance of this grant, let it be known by saying aye.
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 Any opposed? And again, there is none. So thank you. Do we have more in the budget presentation?
Yes, sir. I have one additional item. Last month, I also gave a statement regarding the closeout of the year. I'd like to inform the board that the El Paso County Financial Services will be presenting the preliminary year-end financials at the March Board of Health meeting. As has been the standard practice, we want to make sure we have all the financials prepared and final. We have a few matters that we're closing out on our grants. This allows for our standard year-end processing to allow for invoice processing, along with the standard year-end accounting processes, which we're expecting to close out later this week or early the following week. So I just wanted to make sure we have those finalized before we present them to the board. I'm certain that we'll be able to present them in March, along with the January and February financials for 2024. Any questions on that? Okay, thank you very much.
Any questions? Thank you.
All right.
Okay, and that brings us to item 6 on the agenda, resolutions. And Lori, I think you're going to read resolutions for us. And I think we've got 2 that are for retirement. So when we read those resolutions, if we could have the retirees, if they're present, please come forward.
So the first resolution is to recognize the retirement of Shannon Eli. Resolution of the El Paso County Board of Health. Whereas the El Paso County Board of Health, or Board of Health, announces the retirement of Shannon Eli from El Paso County Public Health, or Public Health, after 31 years of service. And whereas Shannon served as the Operations Supervisor, a position she held for 9 years, and whereas she served as an Operations Technician for 9 years, from 2006 to 2015, and whereas she served in the Women, Infants, and Children program as an educator for 14 years from 1992 until 2006, and whereas Shannon oversaw the renovation of the Valley High Women, Infants, and Children, or WIC office, receiving an award for the project, and has led the Public Health South renovation, and whereas Shannon played a critical logistics role in multiple incident command system or ICS efforts, including the 2012 Waldo Canyon fire, 2013 Black Forest fire, and the COVID-19 pandemic. And whereas we thank her for assisting with Public Health's move from 301 South Union to the Citizen Service Center in 2011, and her dedication to improving operations across public health. Now, therefore, be it resolved that the El Paso County Board of Health hereby expresses its gratitude to Shannon Eli for 31 years of public service and wishes her well in retirement. A move seconded and adopted by the El Paso County Board of Health at its meeting held February 28, 2024.
So moved.
We have a motion and a second. All in favor of accepting this resolution for Shannon's retirement, let it be known by saying aye.
Aye.
Aye. And I'm going to open it up. I think we're going to have some comments here. I'm pretty sure Susan has some things to say.
Sure, and I would welcome anyone, you know, in the audience as well. So Shannon is the one in the gray suit. So, and Lonnie is on her left in lavender. And Shannon has been such a bright light in our agency, serving so many years, doing it professionally, consistently, and with such a positive attitude. I have very fond memories also of us being at 301 South Union Boulevard, right across from Prospect Lake, and just, you know, every single day, every interaction that I've had with Shannon and that others have had with Shannon is that she has always had such a positive willingness to help, public servant attitude. And we are going to miss her. And we've just talked about that it's bittersweet that retirement, and we all have to move on at some point. And I know that she has, you know, other journeys to take, but we had a retirement gathering also for Shannon, and a lot of her colleagues spoke up as well. She has been so involved with our agency, and one aspect that I think is very significant, in addition to all of the emergency responses that we've had whether it's the Waldo Canyon Fire, Black Canyon Fire, H1N1, COVID, all of these. Shannon has been involved in that when we've had to quickly shift to our continuity of operations plan, and we did that very quickly with going all remotely. And Shannon has been behind the scenes and been so much support with our purchase of the Public Health South building to serve residents in the south portion of El Paso County. She's played a significant role with improving a venue that was using for weddings and events to a clinical emergency response type of venue of big vaccination clinics, drive-through testing, securing vaccine. I know more about generators than I want to know through conversations with Shannon and having backups to protect the vaccine and such. So she's just an outstanding public health professional, and so I wish you all the best on behalf of all of the all of your friends and colleagues at work as well.
Any other comments?
Thank you, Mr. Chair. So I just wanted to thank you for the work you've done. We had a deputy director retire yesterday from the county, and it's just so great to see all the work, the dedication, and the commitment to our community. I know it can be a difficult job, but doing this is something, the kind of work that you guys do, that you do it because this is what you care about, and you care about our community and doing what's good for us and our community. And so I thank you for all that. Thank you.
Okay, I'm going to have some things to say, but I'll wait until the very end. Oh, I'm sorry, Councilman Donaldson.
Yeah, thank you, Ted. And I also want to thank you for just the length of your service to the county and to the people that live here and helping to take care of them. And I see this too on the city side. When people like you finally retire, you have a bunch of knowledge, which is just from your experience. Institutional knowledge can't be replaced. I mean, the new person may be great and do an excellent job. I'm sure they will, but you have the history. And unfortunately, it seems like it's rarer and rarer that people stay in one job, with one organization. And I want to thank you for doing that and for helping to make El Paso County and Colorado Springs the place it is to live. Thank you very much.
Mm-hmm. Okay, Lori, can we do this second resolution?
This is a resolution regarding the retirement of Alana Lonnie Donovan. Whereas the El Paso County Board of Health or Board of Health announces the retirement of Alana Lonnie Donovan from El Paso County Public Health or Public Health after 26 years of service. And whereas Lonnie currently serves as an executive administrative specialist, a position she has held for 16 years. And whereas she served as a program assistant in the Drug and Alcohol Counseling and Prevention Program for 3 years from 2004 to 2007, and whereas Lonnie served as a child care worker in the Drug and Alcohol Counseling Prevention Program for 7 years from 1997 to 2004, and whereas Lonnie has played a critical role in training clinical services administrative staff, supporting quality improvement processes related to implementation of an electronic health record and billing services, the COVID-19 pandemic response, and assuring clinical services are delivered in a manner that demonstrates service excellence. Whereas we thank her for her work to improve our medical billing capabilities, assisting with Public Health's move from 301 South Union to the Citizen Service Center in 2011, and serving on our initial quality improvement team for agency accreditation from 2012 to 2015. Now, therefore, be it resolved that the El Paso County Board of Health hereby expresses its gratitude to Lonnie Donovan for 26 years of public service and wishes her well in retirement. Moved, seconded, and adopted by the El Paso County Board of Health at its meeting held February 28, 2024.
Okay, we need a motion to accept.
Move to approve.
Thank you.
Second.
And thank you.
It was a photo finish.
All in favor of accepting the resolution as read, let it be known by saying aye.
Aye.
Aye. Again, that's unanimous. Susan, comments?
Yes. So Lonnie, as you can see, 26 years, and I know her and Shannon are good friends, and I have fond memories also of working together very closely at 301 South Union Boulevard. And what comes top of mind for me with Lonnie is adaptability, and as well as Shannon. But adaptability, brings back memories of the drug and alcohol program, McMaster's as it was called back then. And throughout the years, I mean, there's been many changes as it relates to public health programming, and Lonnie has been adaptable through it all. She has helped our agency within the quality improvement realm when we made significant efforts to get accredited, and she has helped us in every aspect of clinical services. And her role has been critical, and one of the roles has been third-party payer billing, and we had not had that ability to do. And Lonnie has helped out significantly, which has resulted in actually dollars to the clinic and getting reimbursed. And there's so much more that Lonnie has taken part in and been such a leader throughout our agency. I've always appreciated that Lonnie has come directly to me with any issues or concerns, and I greatly appreciated that because, a lot of times I don't have, I'm not, throughout the agency, but she made sure to bring, issues to my attention or any concerns, and I greatly appreciated that, just the communication and the support and the trust that you extended to me and also throughout your colleagues. And both Shannon and Lonnie they're like bright lights, and so you both will be tremendously missed because when you see each one of them, it's always a helpful attitude. It's always like a burst of sunshine. It's not like someone that walks down the hallway and holds their head down and doesn't say hi. It's always just a wonderful interaction, and I know I will miss that. I'll miss some of the kind of chatter around the Broncos and how well they're doing or not doing. But Lonnie, we appreciate your service and much like Shannon, I mean, you both will be tremendously missed. And I see some head shaking in the background and know that I'm sure that there are some on camera, but you both are highly valued, appreciated throughout our agency for so many years, and you will be very missed. And so I hope both of you come back and say hello every now and then. And when we have future retirements, I'm sure that I'll see you at some of the get-togethers as well. But job well done for both of you. Thank you.
Any other comments? Well, I said I'd have some comments. Oh, I'm sorry.
Oh,
Dave.
Oh, thank you, Mr. President. And Lonnie, it's really the same thing. I want to thank you for your this service, to the county and this organization. You also, as it was just pointed out, you carry that institutional knowledge. You've been working with public health for 26 years, and when you go, the next person, I'm sure will be great, but they won't have the just the knowledge and the experience that you have. So I personally want to thank you for what you've done for public health and the county and the city to make it what I think is a great place to live in your work towards improving public health. So thank you very much.
Okay, my comments are real similar to what Councilman Donaldson just said. 57 years standing in front of us, 57 years of experience that is retiring today, or is today the last day?
2nd of February.
Oh, okay. All right. So you're well into the retirement mode. But 57 years of experience is walking out the door, and we're grateful for that. We're grateful for the time, the effort, and the energy. I love the resolutions that we read. They're so professionally stated, and they go through an accounting of your career and the things that you've done and how you've contributed to our county. But it's woefully inadequate to read a resolution and think that that's all the thanks you get after 31 years and 26 years respectively. The thanks go much further than that. And if we were able to get everyone in this county together who you had an impact on by the work that you did, the line would be truly long, and we would be here all day hearing notes of gratitude for the work that you did. So thank you very much. We appreciate all that you did for our county. We appreciate all that you did for, as Susan mentioned, the positive attitude and the things that you did just around the workplace to make it a welcoming and wonderful place to work. Those things aren't overlooked either. We're very grateful, and we wish you the very, very best in retirement. And being a retired guy, it's awesome. You're going to enjoy it. So, thank you. And I think we're going to do a photo, too, with them. Susan, where do we do that?
Right up here.
Right up here in front? Okay.
I think the commissioners can lead the way. I think they can show us.
All right. Okay, that takes us to the next item on our agenda. I think we have another resolution for compensation for our public health director.
We do, and Mr. President, I would like to clarify that the resolution regarding compensation and the employment contract are two separate items. So the resolution I'm about to read relates to compensation only.
Understood. Thank you.
This is a resolution regarding compensation of the public health director. Whereas pursuant to Section 25-1-508-5C Roman numeral 1 CRS, the El Paso County Board of Health or Board of Health has the power and duty to employ a public health director for El Paso County Public Health or Public Health to serve at the pleasure of the Board of Health as the administrative and executive head of public health. And whereas Susan Whelan currently serves as public health director for public health, and whereas the Board of Health evaluated Ms. Whelan's performance during her annual review held on January 25th, 2024, finding her work and leadership to be exceptional and having no concerns. And whereas the Board of Health also reviewed the salaries of other members of county leadership and of other public health directors in Colorado. And whereas, in consideration of the above, the Board of Health wishes to increase the annual salary of Susan Whelan, Public Health Director, by 3% as a for performance increase in recognition of her exemplary performance effective January 8th, 2024, and resulting in an annual salary increase to $218,390.42. Now therefore be it resolved by the El Paso County Board of Health, 1, that compensation for the Public Health Director shall be increased annually per the provisions set forth above, and 2, that any future salary adjustment for the Public Health Director position may be made by the Board of Health either by resolution or by direction given to staff at the sole discretion of the Board of Health. Any cost of living increase or other across-the-board increase in benefits provided to full-time public health employees as a whole will apply likewise to the Public Health Director. Moved, seconded, and adopted by the El Paso County Board of Health at its meeting held February 28th, 2024.
Okay, board members, I'm looking for a motion to accept this resolution.
So moved.
Thank you, Doris, and a second.
Seconded.
And Mayor Havenier, thank you. All in favor of accepting this resolution, let it be known by saying aye.
Aye.
Aye. Any opposed? And it passes unanimously. Thank you.
Mr. President, the next item. Oh,
Just a moment.
Yep.
I'm sorry. Okay, Lori.
Thank you. The next item is the employment agreement for Ms. Whelan as Public Health Director. She is currently, or she previously had an employment agreement which has since expired at the direction of the Board of Health. I updated that agreement, and those updates can be found in the redlined or edited version of the agreement, which is found in your packet. I don't have a presentation to necessarily go through those with you. Most, if not all of those, are simply updates in nomenclature, updating the salary that was just approved by the Board of Health, and just clarifying some of the, again, nomenclature and wording that was used that didn't quite fit with the roles of the Board of Health as the governing board and Public Health as the agency that Ms. Whelan oversees. I'm happy to answer any questions if you have any. Ms. Whelan has reviewed the contract and has no concerns with any of the edits proposed by the board, and I don't believe she has any additional changes requested. So if the board does adopt this contract today, a clean version will be presented to the president and to Ms. Whelan for signature.
Okay, Doris.
My question to you, Lori, is on the last page, number 16. You know, email is not there. It's got fax and postage and all that. Is there a reason why email was left out?
No, this is how the contract previously read. And no, I'm not aware of any reason why email would be left out.
That's a mode of communication that might be something we'd want to include, but maybe not.
We certainly can do that. We can certainly do that if that's the desire of the board, absolutely.
I think that we do have a general email for the board, which would be appropriate, and we get those forwarded to us rather than putting in any personal email accounts.
That's true, Mr. President. My concern with that is if we're going to use email in this contract is that does go through staff, and I don't know if that might raise any concerns if an email directed from the director regarding this contract to the board president is somehow delayed or lost, or because it has to go through staff. I just want to not raise any
No, that's a good point. Thank you for bringing that up.
Questions about staff.
I would suggest then leaving email out because we can vote on the board president annually, and I would hate to have to amend the contract annually based on just changing an email address. This way, it would would require somebody to actually put a letter together and forward that letter via the address that is provided, and I think that that is an adequate means of communication. Any other discussion from board members? Dr. Vu.
Laura, I have a question for you in section 7, the first sentence. At least 5. I see that it was changed from 3 to 5. Therefore, I'm assuming that used to be 3 out of 5, and now the intention is 5 out of 9. Therefore, I'm assuming that there might be future changes. Do you think it's appropriate to either clarify at least 5 out of 9 board members, or to change 5 to majority?
So I don't know why it previously said 3. Excuse me, I did not review this contract the first time that it was entered into, and if I had to guess, I believe it was probably a holdover. There are similar contracts in place with the county administrator and the county attorney on the El Paso County side of things, and a majority of the Board of County Commissioners is 3. So I'm guessing that was simply an oversight when this template or this form was used for Ms. Whelan's contract. So it should have always said 5. Having 3 in the past was an error. So I'm comfortable leaving it at 5. Or if we could also simply remove that clause, because the previous clause says that employment may be terminated by a majority vote.
Correct.
And the inclusion of 5 is simply to clarify the number, but it's not necessary.
Correct. That is my whole point. My whole point is, so either to clarify it even more that it is, the intention is the majority, 5 out of 9, or just make sure that for future purposes, to make sure the clear understanding is the majority.
I think that by including the 5, that would cover situations where less than the full board is present. So for example, if only 7 board members are able to attend a particular meeting, like today we don't have 9 members present. By leaving the numeral 5 in there, it would clarify that even with less than a full board present, it still takes 5 members to terminate employment. It wouldn't be 4 out of 7 or
Correct.
3 out of 5.
It's not majority of the quorum, but majority, what we need is a majority of the board, not majority of
the entire
quorum.
board.
Therefore, I think if we include a 5, then it's good in order to avoid future similar overlook, to clarify that it's 5 out of current or 5 out of 9 board members, for example.
Okay, so if you could clarify for me, Dr. Vu, do you think that further clarification is needed beyond how it reads now?
It would be at least 5 out of 9. So add out of 9. Because in the future, right? What if the board in the future becomes 13, for example? Then the intention is more clarified now that the intention is 5 out of 9, not 5 out of 13 in the future.
I'm happy to add clarifying, language if it's, if that is the desire of the board. I would not recommend saying at least 5 out of 9, because I don't want to give the implication that 9 board members are required to be present. The intent is that the majority vote be at least 5 members, but that doesn't imply or that 9 board members need to be present for the vote.
That is true. Then if that's the case, then in my mind it's probably good to say the majority of the board, i.e. so-and-so.
Sure. We can come up with some clarifying language to fulfill
right,
your
because
intent.
right now I'm looking at it as 2021, were there 5 board members? I'm thinking back, no, there was more than 5 board members. And at that time, if we only had 3, then that's a problem.
Right. Agreed. So yes, if my recommendation is if the board as a whole desires to make that change, then that would be incorporated into any motion to approve that is made. So a motion to approve with the amendment to paragraph 7, as stated by Dr. Vu, will come up with some language to accomplish that intent and incorporate it before signature.
Thank you. Therefore, I'm not sure how to motion this, but I motion whatever Lori just said.
Any further discussion from board members? Okay.
I will second Dr. Vu's motion.
Okay. And all in favor of accepting this resolution? Well, it's not a resolution. This is the contract, approving the contract as it has been amended by our county attorney, and with the caveat that paragraph 7 will be further amended to address the discussion we just had. All in favor of that, let it be known by saying aye.
Mr. President, could we just have the attorney state what that amendment is, like clearly?
Certainly.
Would you like me to come up with the language now or just state the intent that we're trying to achieve?
It's fine just to state the intent.
So the purpose would be to clarify that in order to terminate the contract, a majority of the entire board, or a number equivalent to the majority of the entire board, would need to vote in the affirmative to terminate employment, regardless of how many members are present.
Okay, thank you.
Thank you. I clarify my motion as what Lori just said.
Okay. All in favor? Let it be known by saying aye.
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 Any opposed? And again, that passed unanimously. Thank you, Lori. That was a lot of work that was done with that. I also would like to thank Xavier. I know that he contributed as well to this contract language and had some questions for Lori that she addressed in some emails. So I appreciate the work that was done to get that up to date. And now we're going to move to new business, and I'm going to turn it over to Councilman Dave Donaldson to introduce our guest.
Yeah, thank you, Mr. President. And today we're fortunate, we're lucky enough to have Dr. Kenneth Finn come and talk to us about cannabis and opioid use in Colorado Springs. And I think many of us are familiar with Dr. Finn. And his credentials will speak for themselves when he lists them out. He's spoken to the county commissioners, to city council before, I believe this body before I was part of it. And what I truly appreciate is he's the expert to speak on this, and he speaks to it based on the science and the medicine. It's not based on opinion. It's not based on what we wish was the truth, but it's based on the facts. And he separates that out from a lot of spin, which is done by, perhaps even both sides. And he focuses on the facts. So with that, I welcome Dr. Finn and look forward to his presentation.
Thank you, guys. Can you hear me all right?
Yeah.
I appreciate the opportunity. It's weird to be talking normally like this to an audience, but again, I appreciate all the members allowing me to do this presentation. Just a short background on myself. I've been providing medical care to this community for 30 years. I am currently board certified in rehab medicine, and pain management. I am the current president of the American Board of Pain Medicine and have been on their exam council for over 30 years, writing test questions for physicians that want to have a higher level of expertise taking care of patients that have pain disorders. I ended up down this road as a pain physician because I saw patients on high dose of opioids and high levels of pain, and using marijuana didn't make any clinical sense. So the next thing I know, I was on our governor's task force for Amendment 64 and the Consumer Safety and Social Issues Work Group. I served 4 years on our state's Medical Marijuana Scientific Advisory Council. I edited a medical textbook called Cannabis and Medicine, an evidence-based approach with 70 authors from 4 countries, 20 chapters, and a year and a half of my life I won't get back. I also founded a nonprofit called ISAC, the International Academy on the Science and Impacts of Cannabis. And ISAC is now a member of the Vienna NGO Committee on Drugs, and we work with the UN on international drug policy, and our space is the cannabis wheelhouse. I speak internationally on this, going to the United Nations last year. I've spoken to Mayo Clinic, UCLA. I work with a lot of state legislators on when they're entertaining going down this road and trying to provide some level of clarity to them, because there's a lot of confusion out there on whether it helps, what it does help for. And I really approach this primarily from a public health and safety perspective. And again, I appreciate the opportunity for allowing me to present with you. My normal talk goes about hour 15, and this is a very truncated presentation. I want to kind of hit the primary points, and I want to have some time for questions. And I'm always happy to come back and provide more. And you all have my email, and you're always free to email any questions or concerns that you may have. So this was taken last week at our one of our retail marijuana shops in Manitou. And you can see the Girl Scouts of America are front row selling their wares outside our marijuana shop. We don't have time to talk about the impact of advertising to youth. The science and literature shows that you advertise to youth, there's more likelihood of that youth using marijuana. So this, I think, says a lot in a short amount of time. I want to focus on a few points. One is going to be our opioid epidemic. This is El Paso County, and this is the number of medical marijuana patients in our state. And you can see that El Paso County has the highest concentration of medical marijuana patients in the entire state of Colorado. The most common reason for patients to be recommended a marijuana card is for pain. On a personal note, and out of curiosity, I applied for my medical marijuana card a couple years ago. And I didn't make anything up. I was a very active youth. I still remain active. I need my knees replaced after 5 surgeries. So after $250 and a 15-minute time slot on telehealth, I was approved for severe pain in a minute, 60 seconds. There was no questions on my past medical history, my current medication usage, my history of marijuana usage, which full disclosure, I don't use. I was never even asked my level of pain, and in a matter of 60 seconds, so I was approved for severe pain. So that's the most common reason why people are recommended in the state of Colorado and across the country. So here's a little graphic that I'm going to go through. Here's our overdose death rate going back to 2002. And if you recall, if you're here long enough, we voted to legalize for medical purposes in 2000 and implemented in 2001. Knowing that the vast majority of marijuana cards are for pain, and the platform, one of the platforms to legalize, is going to help our drug problem in the country and, more importantly, in the state of Colorado. But this is what happened in the state of Colorado, knowing those points. And the darker the color, the worse the death rate. So there's 2002, 5, 8, 11, 14. It has not improved our death rate. And the fact that this is CDC data, the fact that the number of prescriptions are on the decline, our drug problem worsens, partly to the fentanyl scourge that's happening across our nation. And now we have the nitazines and all these other medications and drugs that are flooding our borders and our states and our communities. This was a more recent 115,000 drug overdoses last year, knowing that the more states are legalizing for marijuana use. With the platform, it's going to help our drug problem. Prescriptions are going down, but our deaths continue to worsen. So the fact of the matter is that marijuana legalization for pain is not helping and probably contributing to our drug crisis. This is Colorado Department of Public Health and Environment data. I work closely with them in this realm. And you can see in this graphic going back to 2000 when we voted to implement, and 2001 when we actually did implement our medical marijuana program. It lied dormant for several years because there was no infrastructure. I mean, physicians were afraid to recommend due to fear of prosecution or litigation. But after a lot of politicking at the state level, in 2009, we had, for lack of a better term, de facto legalization. When the marijuana dispensaries opened across the state, even to this day, there are more marijuana dispensaries in the state of Colorado than the number of McDonald's and Starbucks combined. It's easier to get a marijuana than it is a Big Mac or a latte. In 2012, we voted to legalize for recreational purposes and implement it in 2014, and that's when I spent the time at the state level. And you can see over time, our drug problems have worsened. Interestingly, heroin is as readily available and cheap as it is going down over time. And I think the fentanyl is the new heroin. But other drugs like cocaine and methamphetamine and other stimulants are worsening. This is the 2019 data. There's the 2020 data, and I mean, interestingly, looks like the COVID curve. And you can see that all these drugs continue to worsen in terms of our overdoses. Last year, or 2021, they actually had to compress the graph because in the state of Colorado, our drug deaths continue to worsen. Interestingly, heroin is still on the decline, which is the kind of the orange line. I did get the 2022 data, and I think our 2023 data should be out in a few months. I'm hopeful that maybe this is a turning point for the state in terms of education, harm reduction, et cetera, that we should be doing. Interestingly, the very bottom line, you can see the number of marijuana mentions are going up. People are not dying from marijuana poisonings, although technically they can, but they're not stopping their breathing because of their marijuana use. So I'm trying to work with our state and national medical examiners and coroners to try to clarify and quantify what is going on here. Is this simply a companion drug? They're not differentiating between the natural cannabinoids and the synthetics like K2 and spice. They're not looking for the metabolites like cathinones that are found with the synthetic marijuanas. But interestingly, in the state of Colorado, you can see a very slow increase in marijuana mentions in our drug deaths across the state. This came from the CDPHE. You can see that this kind of is reminiscent of the pill mills, in my view. We had 3 physicians recommending more than 5,000 to 8,000 marijuana cards in the year 2022. If you do the math, that's like 1 patient every 15 minutes. There's absolutely no way a physician can do a comprehensive physical examination, a history, and come up with a treatment plan. This is certainly a reminiscent of the pill mills. In Washington, D.C., you don't even need a physician's supervision to be a medical marijuana patient, which is kind of strange. And that happened around June or July of 2022. And you can see the number of marijuana patients in Washington, D.C. spiked. You can go to a kiosk, enter your information, and say, yes, I have pain, therefore I need my medical marijuana. And you do not need physician guidance or supervision for that. I published a paper a couple years ago, and we have another one coming up. Archie Blyer is a pediatric radiation oncologist from MD Anderson, and Brian Barnes, they're now in Oregon, and myself published a paper that opioid deaths have actually increased more where marijuana was legalized, and fentanyl death rates are actually higher in marijuana legal states, both medical and recreational. And there's the graphic from that paper. And you can see that in the green, the marijuana legalizing states had a much higher fentanyl death rate than the non-legalizing states. This is a very important slide to understand. The #1 risk factor for an adolescent to misuse their opioids is having ever used marijuana. That's the #1 risk factor. Yeah, youth use a bunch of stuff. They drink alcohol, they smoke cigarettes, they do illicits. But the #1 risk factor for an adolescent to misuse opioids is having ever used marijuana. That came from the Youth Risk Behavior Survey from 2020. Another interesting data point is that, if I'm looking at the addiction in adolescents, and I was very surprised about this data as a pain physician. So after 3 years of first trying marijuana compared to opioids, marijuana actually has a higher percentage of addiction in adolescents, almost twice as much compared to opioids, especially in the early onset users, the 12 to 17-year-olds. And Wadaker, interestingly, published a paper that the predominant predictor for an adult to misuse opioids is having used marijuana before the age of 18. So I don't have time to get into all the science, but there's a very intricate relationship between the opioid and endocannabinoid system. In terms of both of them modulate pain pathways, they do very similar things when activated. So there's a very tight relationship between opioids and cannabinoids. I'm going to shift gears right now and talk about another important aspect of cannabis is in utero exposures. The SAMHSA data, Substance Abuse Mental Health Administration, January of last year, looked at the number of women that are using during pregnancy. And you can see near daily use of women who are pregnant has gone up over time since 2010. in the total pregnancy, the marijuana use in pregnant women is going up. So this is a problem. A couple of bullet points I want to highlight on this. Here in Colorado, more than 70% of the 400 dispensaries surveyed recommend women use during first trimester pregnancy, which is a critical period of development of the fetus. And we know that even after birth and postpartum, THC can persist in breast milk for 6 weeks. And we know that there is an impact on brain functioning related to prenatal exposure, and that was based on a functional MRI study. One thing that's very important is CDPHE is not doing this, and I'm not aware that El Paso County Board of Health is doing this, is tracking these baby exposures. I know Bob Kiley at UC Health, I mean, he was showing some data on our methamphetamine problem, but I've been talking with Bob for several years on this, and he knows that our marijuana exposures in babies is at record levels. And nobody's paying attention to this. Nobody is tracking this. I think CDPHE is on the cusp of trying to get this data, and I think it's very important for our public health department to start tracking this data, because I'm going to tell you what's going to happen to those babies. This came from the state of Connecticut, and they looked at substance exposures over 28 months, so about 6.6 babies a day in the little state of Connecticut. And the vast majority of those babies were exposed to marijuana, nearly 80%, compared to 20% for opioid exposures and less than 3% for alcohol exposures. And we know what the implications of like fetal alcohol syndrome are, et cetera. But the vast majority of exposures in babies is related to marijuana based on Connecticut data, but not a lot of states are tracking this at all, even California, Washington, Oregon, Colorado. We're not looking at this, and it's important that we do take a critical eye on substance exposures. So has anybody heard of the ABCD study on this panel? I can't remember what the acronym is for, but what happens to these babies that are exposed to marijuana in utero? They're tracking about 12,000 people over time. And exposure after the mom knew that they were pregnant, there were problems in these babies that were exposed with attention, thought, social interaction problems, psychotic-like experiences, even though they may not be using. And these are 10-year-old children. So I did a PubMed search. I'm like, well, women use a lot of stuff during pregnancy. They use tobacco, alcohol, other illicits, methamphetamine, cocaine. And I try to see, is there any evidence of psychotic-like experiences and exposures to these other substances? And I found nothing. It seems to be very unique to marijuana exposures. So we know prenatal cannabis exposure is related to a higher risk of psychopathology in the offspring, even into middle childhood. The National Institute of Health, NIDA, and NIDA, around the same time, followed those kids into early adolescence, and those symptoms persisted. So these are lifelong impacts in utero exposures. And again, they're tracking 12,000 youths. Just a few months ago, about 6 months ago or so, they came out with another paper following these kids. And I don't think I have in this slide deck, you know, that slide between early onset use comparing marijuana to opioids. But we know we want to delay onset of use just because the brain is developing until 25 years of age. Some people are saying even 30 years of age. So the #1 risk factor for a person to have early onset use is having been exposed in utero. And that remained when controlling for other things like alcohol, tobacco, et cetera. And here's the graphic from that paper. I think it was I can't remember if it was a JAMA paper, anyhow. You can see the graphic. The #1 reason for a person to have early onset use is having been exposed to marijuana during pregnancy. This is a state of Texas data point where you have a child abuse or neglect fatality in the state of Texas, which represents about 10% of the US population. It's a huge state with a lot of people. Other states are not tracking this, and I think it's important that we do look at this stuff with a critical eye. The substance that is found when there's a dead child in the state of Texas, either by the perpetrator, either active use or past use, is marijuana. And #2 is nothing. And so it certainly leads the pack when there's a dead child in a state that has to be looked at their drug use. And then it's followed by the usual suspects, the opioids, alcohol, et cetera. In the state of Florida, the same thing. When you have children maltreatment and death, marijuana is the #1 substance found by the perpetrator. Florida, the same data. Colorado's not tracking this data. Just recently, I mean, just about a year ago, a couple years ago, 2 years ago actually, March 24, 2022, there was a child that shot himself in a car outside a pot shop in Manitou. You know, that was, I would assume that his parents were users. Fremont County, just an hour south of here, a 1-year-old child was run over by his father, who was stoned at the time. Child neglect charges filed after a woman in Virginia, her child died. Oh, this was a Wisconsin case, pardon me. This was just last month or this month. Boy had brought in for seizures. He had a THC gummy. He had acute cannabis toxicity, intubated, respiratory failure. Child poisonings are going through the roof. This is marijuana-related exposures by age groups 5 and under, and you can see there's a significant rise in poisonings. We have increases in Poison Control Center. This is a paper from the American Academy of Pediatrics. There were an increase of 1,375%. That's not a little jump. It's not a 100% increase, which is doubling. It's way worse than that. Of the kids that were exposed to marijuana, 70% of the cases that had a known outcome had central nervous system depression. 23% of them were admitted to the hospital, nearly. Here's the graphic from that paper, and this was American Academy of Pediatrics about the number of pediatric poisonings. Another paper from American Pediatrics showing the same data point, 13.3% fold increase. That's a 1,300% increase. And this is a large study, 52 children's hospitals and the Pediatric Health Information System Data Bank. 50% of those kids were inpatient, 15% required intensive care, and 4% required mechanical ventilation. They were intubated. Little children do not metabolize cannabinoids like the adult. And if you have candies that are attractive to children, they're going to eat them. In the country of Canada, they're having the same problem. The number of pediatric exposures and poisonings are going up. Interestingly, if you look at the province of Quebec, their curve is flatter. Does anybody have any idea why their curve would be flatter in that province alone compared to the other provinces? Any thoughts? Quebec has a potency cap. They restrict the products to 30%, which I think is still too high. The other provinces in Canada allow a high potency, much higher potency than 30%, and you can see their kids are having more problems. Emergency room visits, I don't know if anybody has talked to any of our local emergency room physicians, but we're seeing poisonings on a daily basis, cannabinoid hyperemesis, all the time in the emergency department. This is what happens to the older people like us. I hate saying it, but I am getting old. The Journal of American Geriatric Society looked at the cannabis-related emergency room visits in the state of California. 1,800% increase in any person over the age of 65 going to the emergency department in the state of California for cannabis poisonings. And California legalized marijuana in 1996 and then legalized several years ago. And is this a result of that promotion of cannabis use with older people that may have problems? For example, does anybody have any idea how many drug interactions CBD has? Dr. Vu, I'll ask you, I'll put you on the hot seat. Take a guess on how many drug interactions CBD has. 590 drug interactions. And so when I have conversations with my patients, and particularly an older person, and they say, well, I want to use a CBD tincture or cream or what have you, and I go to drugs.com and you can say, well, you're on meloxicam, for example, which is an anti-inflammatory. I said, well, let's look at the drug interaction on drugs.com between meloxicam and cannabidiol. It's a moderate drug interaction with liver disease, liver failure. And actually the folks that fast-tracked Epidiolex through the FDA, which is a purified natural CBD for a narrow-spectrum pediatric seizure, they wrote my chapter on seizure. So my book actually has an all-star cast, and that's a very fascinating chapter to read if you're really into that type of science. But the fact of the matter is that the general public has no idea of what is going on and what risks they have. Another major interaction is a blood thinner called warfarin or Coumadin. It can increase your or thin the blood out even more just by the way it is metabolized through the liver. I actually had a patient who had an INR of 7.8. Which I've never seen before because they were gobbling up a bunch of CBD products, and I won't get into how bad that is, but it's bad. Here's the graphic from the geriatric exposures. I published a paper in 2018 looking at our local community, how much money was lost at Penrose Hospital between 2009 and 2014, which is just on the cusp of legalization in the state. And I had the CFO sign an attestation that Penrose Hospital lost $20 million over the 6-year study just from marijuana-related emergency room visits. And it's gotten worse. And if you take that hypothetically across the state of Colorado, which has 25 emergency departments, that's a $500 million price tag. I mean, this is an addiction for profit industry that is creating other societal costs. I mean, did we do a good job with tobacco? No. Alcohol? No. Opioids? No. And now we have another addiction for profit industry that's causing more societal impacts. September is Suicide Prevention Awareness Month. Here's some of the suicide data in the state of Colorado. And interestingly, El Paso County stands out again. We have a terrible problem with suicide. In the state of Colorado, marijuana is the most prevalent substance found in completed teen suicide in the state. I think this was 2020 data. And the more recent data, nearly 43% of a child or an adolescent that completes suicide is positive for marijuana. That is a frightening data point, and I think it's important that we track that not only locally but also statewide. And I think CDPHE is doing a very good job at compiling data. I do give them a lot of credit. Across the state, in non-natural, non-homicide deaths, residents in the state of Colorado younger than 25 years of age, the #1 thing present in suicide is nothing. But the #1 substance found is marijuana, more than alcohol, more than opioids, more than other illicit substances. The association between marijuana laws and suicide in 12 to 25-year-olds between 2000 and 2019. Medical marijuana and laws and recreational marijuana laws are associated with increased suicide-related mortality, particularly in young females. Youth between 14 and 16 had higher rates of suicide in states with recreational compared to states with just medical and states without medical. So this is just simply another problem that we're having to contend with our youth. They're struggling. I would not want to be a kid these days. There's so much pressure, and I mean, suicide is a complex thing, but I think one piece that people don't talk about is the marijuana piece of the puzzle. There's social media, there's bullying, there's all these pressures that these kids are going on under. So I think there's a lot of factors that go into suicide, but marijuana is definitely a piece of the puzzle that people tend to ignore. This is another very important paper that came out May of last year, because the vast majority of kids that use do not have cannabis use disorder, right? This is on what happens to those kids that are just using. They have non-disordered cannabis use. Past year, non-disordered cannabis use 4 times as prevalent as those kids that do have cannabis use disorder. And those kids have 2 to 4 times the odds of all adverse psychosocial events, including major depression, suicidal ideation, difficulty concentrating, trouble with their GPA, truancy, aggression, fighting. And these are the kids that are not having trouble with their use of the substance. Psychosis is a big problem. I don't know if anybody knows much about cannabis psychosis, but it's real, it's dangerous, can be deadly. This came from CDPHE, January of last year. Frequent marijuana use by Colorado youths is associated with psychotic disorders, and that does include schizophrenia. So there's one of our advisors from London, Sir Robin Murray, and his wife, Marta DeForti, have published a lot of papers with the strong correlation between cannabis use and schizophrenia. There's one person from Denmark who's on our advisory panel, actually shows a causal relationship using the Bradford Hill criteria, which I'm not going to get into right now. But the fact of the matter is that there's a strong relationship between cannabis use and mental health issues. Talk about crime. Noah Harpham, you guys remember him? He was the Halloween shooter a few weeks before the Planned Parenthood shooter. He had a rifle in a hand, a revolver in the other. He killed a cyclist who was a former Marine. Then he shot 2 women who were ironically in drug recovery that were just downtown, and he was killed just downtown, a few blocks from here, by police. And I have his toxicology, and he had only one thing in his substance. One thing in his toxicology was THC. Robert Deere, who was the Planned Parenthood shooter, a few weeks later, shot a few people. He had an online handle. He was associated looking for sex and marijuana smoking partners, enjoyed marijuana when he used to live in North Carolina. His girlfriend had a medical marijuana card. People share their medical, quote, medical marijuana, unlike other medications, which they shouldn't be doing. Colorado crime is going up across Colorado. I'm not going to get too much into this. Homicides, again, El Paso County tends to stick out a little more than the other counties. Pueblo, Denver County area as well. Homeless are coming to Denver for pot, wreaking havoc on the 6th Street Mall. Welcome to Denver. This came from the Washington Examiner. Colorado, #1 in violent crime in most populous states, twice the national average. Many victims are not reporting the crimes. Lobbying, I mean, it's become very politicized, unfortunately, like anything else. Again, I don't think this is a partisan issue. I think it's a public health, safety, and scientific issue. In the state of Colorado, nearly 50% of the lobbyists didn't even disclose their funders' cannabis affiliation and actually use strategies to obscure the true amount and source of their funding. Fatal crashes, we do have some driving impairment problems in El Paso County. We ranked highest in deadly crashes from impaired drivers in 2021. It's going up over time. This came from the Drug Free America, and I think it links to the Rocky Mountain High Intensity Drug Trafficking Area report from 2021. DUIs related to marijuana are going up, and fatalities related to marijuana are going up. Traffic fatalities increase at about 1.2 per billion miles traveled after retail of recreational marijuana begins. So states who legalized earlier have experienced larger traffic fatality increases, and a lot of this data can be found at AAA, the roadside, the NRS, the National Roadside Survey data, et cetera. This is kind of a talking point, kind of a very sensitive area, social inequity. I mean, this industry is actually targeting the exact population that they claim they want to help. The poor communities of color. Denver's pot businesses are mostly found in low-income minority neighborhoods. The pot warehouses in Denver are booming at the detriment of low-income neighborhoods. And Denver is considered the capital of dispensaries and breweries, but when it comes to black ownership, it's capital of inequities. And there's some links that you're more than happy to read, and I can provide much more information about this. It's really a predatory industry, unfortunately, and it's really making it hard for those communities of color to improve because they're targeting them. That's where you find all the smoke shops and the liquor stores, and now all the pot shops are there. If you go to weedmaps.com, you can look at the graphics and find out where all the marijuana shops are in these states. I'm going to kind of wrap it up pretty quickly because I know I can go on for hours on this issue, but there are environmental impacts. After the Waldo Canyon fire was out, they found a 22-acre illegal marijuana grow with 7,500 plants. The farm had dams, irrigation lines, housing quarters, etc. It didn't start the Waldo Canyon fire, but it was a surprise to law enforcement, and I do a lot of work with law enforcement around the country. It's not just happening in our community, it's happening everywhere. There was an interesting paper that the legal marijuana production in Colorado emits more greenhouse gases than our coal mining industry. So for an industry that prides itself on being green, natural, herbal, and safe, it certainly has a very large carbon footprint. The electrical grids are being tapped into. Water issues have been a problem, particularly in California. And I'm going to wrap it up there and leave it to some questions because there's a lot of other stuff I can get into, but I don't have the time. Cannabis is not a medicine, it's a plant. We have a lot of plant-based medications already. Aspirin, digitalis comes from the foxglove plant. A lot of chemotherapeutic agents come from plants. We have Epidiolex, which is a purified CBD that's approved, FDA approved, for a very narrow spectrum of pediatric seizure. So I support 100% drug development for cannabis-based medications that are natural. So I know I sound maybe nihilistic or prohibitionistic, but I'm not. I'm a scientist, I'm a physician, and I really value the safety of my patients. And I commend El Paso County Board of Health for allowing me the time to listen to what I have to say, and there's a lot more I can go into. We should support potency caps. These products of today are nothing like what we grew up with. The average THC content when I grew up in the 70s and 80s was about 2 to 4% THC. The average smoked flower in Colorado is about 20%, the concentrates are about 50%, and then you get into the dabs, waxes, and shatters of the world that are pushing 95%, some people saying 100% pure THC. They don't look like plants. They look like crystals and gooey substances that you vaporize with a blowtorch. To me, that's not a good delivery mechanism for medication, number one. Eliminate home grows. We know that it's a breeding ground for illegal activity. Our illicit market is alive and well in the state of Colorado, tapping into our law enforcement resources. We have to track, monitor, and document public health implications, healthcare utilization, emergency room visits, birth defects, and again, in utero exposure data, publish environmental impacts. We should have mandatory drug testing in all violent crimes. And the problem that I find, having done this for so many years, a lot of these, and I have, a lot of these mass shooters and acts of violence, there tends to be marijuana somewhere in the history, either in the past or very close to the point of the crime. You know, Noah Harpum, Robert Deere. And the problem is that, and what makes marijuana and cannabis so insidious and covert is that it's out of the urine, out of the blood in a pretty quick time frame. So if you don't get it in that window, you're gonna miss it. So I would support hair testing, which is expensive, unfortunately, and nobody's going to really do that. But I think it's important that we do have violent crimes, have a hard eye look at that. We need to monitor our youth use. We need to have massive education campaigns to prevent early onset use. Delay onset use is going to be the safest thing. I'm not telling, you know, I'm not a prohibitionist saying, oh, you're going to go to hell just because you're using marijuana. I think it's important that you say these are the implications, and I actually published a paper on how to have these conversations with your patients because there are risks. One of my authors is a pharmacist in Denver, Robert Page, who was the lead author of the American Heart Association paper showing the increased risk of sudden death, arrhythmia, stroke, and heart attack in marijuana. The heart is a secondary target organ. The brain is the first target organ. Discourage use during pregnancy and lactation. Follow the American College of Obstetrics and Gynecology and American Academy of Pediatric guidelines. I remind people we were in the middle of a vaping epidemic before COVID hit, so we should discourage smoking and vaping. Toxicology on all suicides. Again, the state of Texas does not test adolescent suicide data, and I think Colorado is the only state I'm aware of that has a mandated toxicology for adolescent and teen suicide. Watch the driving fatalities. So it was the impetus to edit this, which I'll never do again. Found this, which I really enjoy, providing education. We have a lot of wonderful speakers that are free. You can register for free. You can watch anything you're interested in for free. We're not charging money for this. It's really providing education for anybody that's interested in this. And we have the world's experts that are providing at their expense and time graciously education on the impacts in their particular silo. This is what I prefer to do before work. I'm jealous that some people have retired. I would love to retire right now, but it's not going to happen. And congratulations, by the way, and thank you for your service to our community. So I'm going to end it there and leave it open to questions. It's drinking from a fire hose, I understand, and I apologize, but it's a lot to cover.
Well, thank you very much. I'm going to look across. Commissioner Bremer.
I do have a few questions.
Yes, ma'am.
And just wanted to point out some differences for El Paso County from some of your statewide data, because while we have a long way to go, and this highlights the importance of paying attention to the issue and following the data, I think that El Paso County has made some unique steps across the state that I kind of wanted to point out. But so first I wanted to, the data that you were talking about around adolescents and particularly child abuse that occurred in the setting where there was a misuse of substance. You know, I know the state of Colorado, we have a child fatality review team. It's mandatory, it's statutory. Every non-natural cause of death under the age of 18 is reported, looked at. But what I've found as being a part of the commissioner that reviews that, I put it off and I say I only do it about once every 3 years in bundles because I just have to be emotionally and mentally prepared for the cases that I see in that. What I will say is that it's much more designed, rather than collecting the data, it is designed around an analytical and situational, where are the gaps in the systems, right? As opposed to, it's not actually very data-driven. I think you can put together some death data. Our local coroner is great at putting that together and extracting it a bit. but it's not all coming from one centralized space for the data. And as we're looking at those, it's truly what it sounds like. It is a case review, case by case, and it's designed to indicate the gaps in the systems. But it doesn't touch the medical side of the system or the clinical side of the system. It really only touches kind of the social services side. So it's fascinating, and every time I review that, I'm wanting more data, right, to make those larger policy decisions on, and we just don't really have that in Colorado, but I do think we've taken some proper steps on the case analysis of it. The problem is we don't get the case until everything's unsealed, everything's been investigated, and it's 18 months too late for that child. So if we could get into a more proactive, prevention-based analysis of that data, it would be amazing. So that's just a little by point. The other thing I wanted to say, when you were speaking of the high crime rates in Colorado, absolutely, that's true. But recently, the Common Sense Institute released a really great paper kind of comparing counties and what's different about some of them. And El Paso County has a much lower crime rate with actually more citizens and more of the other things that generally contribute to that. So trying to understand and analyze that from a policy perspective, I think falls, it falls into my policymaking role as a county commissioner, but it also follows into a policymaking role here if it's health related. Mental health, I see Councilmember David Lineweber up there. That's his big thing. I think we need to figure out how all of these are working together. And again, we don't really have the data. This is a great start. I wish we tracked some of what some of those other states do. And then finally, just for a little PSA, so to speak, are there organizations that are helping with the community-based conversations or helping parents have the conversations with adolescents? Where can our citizens go to find resources for how to talk about these issues, marijuana in particular, to their young teens?
There are. I mean, our organization is more driven towards the science aspect. Another organization that I'm familiar with is a Smart Approach to Marijuana, or SAM. I don't know if anybody's familiar with them. And then there's more local. There's a Colorado, I think it's One Choice to Grow Up or something along, I can't remember. One Chance to Grow Up. I think they have a lot of very valuable information, particularly with parents. And I think it's, the problem is that really not educating the youth. That's a huge piece of it. And again, it's very, as you mentioned, it's very complex. And I think the point I'm trying to make is that marijuana is a piece of this very complex puzzle that is typically ignored. But I think it's not only the youth that we have to educate the parents. I can't tell you how many people I know that are in education, either principals, teachers, and they are seeing parents coming to school with doing what's called hot boxing. I don't know if anybody knows the term, where they roll up the windows and they Cheech and Chong, they smoke. The parents are smoking in the front seat. The kids are exposed in the back seat. They open the door and the kids roll out of the car, with a cloud of smoke, marijuana smoke, and there's very good evidence on the secondhand exposure to marijuana and its impact on thinking and concentration. But talk to your friends and colleagues that are in education. They see this every day. It's happening every day in our community, and I think it really should be addressed. And I do thank you for trying to take the bull by the horns, and because it's a huge bull, and there's a lot of pieces to it. But I think it is important that we start to address it. I think we are a little behind the 8 ball, but I can tell you Colorado is far in front of many of the states that are trying to go down this road. And all the states I work with, we're going to do it better. Not one state has done it better. But I commend our CDPHE and I commend our local Board of Health Department for trying to compile that data. And I think it's important that we get that data out to the public and we do provide that education because it is so critical, because people have no idea. When I talk to physicians, let alone the lay people of our communities and our country, and of the world, I've spoken to many people around the world about this, I get deer in the headlights. Like, I had no idea CBD had 500, and it changed to 590 drug interactions. And it's just surprising to me because I've been so deep into this for so long. To me, it's like secondary. It's a secondhand knowledge. It's very easy for me to go through and pick up the information out of my brain. But the vast majority of people, let alone physicians, have absolutely no clue. So I'm speaking actually with CDC and NIDA in April at an RX Summit in Atlanta as a 3-person panel because the one person is actually the lead author in the ABCD study from CDC, and another person is on the opioid task force at NIDA. And then me. So I don't know why or how I ended up in this position, but here I am. But I'm always happy to provide information. I'm always happy to come back. Please send me an email. If you have any questions, concerns, I can send you graphics, data, papers. You don't want to see my laptop. It's folders and folders and folders and folders, and each folder is probably 15, 20, 30 peer-reviewed medical articles, and I've read all of them.
Thank you.
Commissioner Gonzalez.
Thank you, Mr. President. I appreciate the information. I did numerous years in counter-drug, understanding all these things in my military career. I actually did an op-ed last year in the Gazette talking about some of this based on HIDA information, and so I appreciate it. All supporting the same type of arguments. And I'll just note that out today is an American Heart Association study report that indicated the increased rate for any use of marijuana for cardiac and I think stroke, and significantly higher, of course, if you're a daily user.
And that is very, sorry to interrupt, but there's a very interesting point. So how is anybody able to track, and this is what I ran into when I published my paper from Penrose. The patient comes in with a heart attack or a stroke, and either they die or they don't die. They're not taking a good drug history. So their marijuana use may have precipitated their stroke or heart attack is frequently missed. And that's part of this whole educational process, is to make sure we're reviewing their drug history. And because people say, oh, marijuana, what's the big deal, right?
Right. And as a question to one of the information you put, in terms of the fentanyl deaths, you said there was some relationship to marijuana. Do you happen to know whether that relationship was related to the deaths, whether it was somebody is using marijuana and then moves on or is using fentanyl, or were the deaths related to, say, fentanyl-laced marijuana, where they were maybe not even knowing they're using fentanyl?
More likely than not, the overdose was related to the fentanyl. The fact of the matter, it could be more likely it's a companion drug. I mean, we can argue about the gateway theory. I think, most heroin users didn't start with heroin. Booze and pot are probably the most common substances used before progression to stronger substances, but that still is up for debate. And thank you for your service. And as you remember, the American hero Chris Kyle was shot and killed by Eddie Ray Routh, who had cannabis psychosis, and he was a vet self-treating his PTSD. I work with some of the VA medical system, which is a nice controlled environment to run and look at experiments, kind of looking at this PTSD and all this other business, but the data's not there that veterans that are using marijuana for PTSD or pain that is any benefit, and actually can be detrimental.
Okay, I believe Dr. Chen, who's online, has a question for you as well.
Yes, thank you. Thank you for that very comprehensive presentation. I think you touched on many issues and topics, and the discussion is probably going to be much longer than this board meeting would allow. I would thank you for bringing up the subject of potency caps. I think that that's a very important consideration, and it may explain why there are overdose presentations in individuals over 65, because they may be thinking that the marijuana products that they're using now is similar to that they used in their youth, which is, a completely different product. So thank you for bringing that up. And I do support the idea of potency caps on these products. I do have quite a few questions that would help to delineate the difference between an association a correlation and causation in some of the issues that you brought up. But I'd like to probably start with the issue of babies exposed in utero, because my background is in women's health, and also the association or correlation that you brought up regarding adolescent use. So I think that my question would be, is there any information on possible confounding variables when it comes to youth behavior after exposure in utero? And specifically, I'm thinking about the possibility of either a genetic predisposition to addiction or a genetic predisposition to a mental health issue for which the mother might be self-treating during pregnancy and then is inherited in the baby to be a mental health issue that presents either in childhood or early adolescence, and also whether the early use in adolescence, rather than being caused by in utero exposure, is simply because that individual is born into a household that has substances readily available in the household for use. As we know from previous studies, the early onset of alcohol or tobacco use was strongly correlated with the availability in households. So I wonder if you could speak to that possibility, rather than drawing the conclusion that in utero or early exposure leads to a lifelong issue with substance use.
Thank you for that very long-winded question. You bring up some very good points, though, because there are some genetic predisposition issues, and then there's environmental issues, obviously. I mean, if you're going to be raised in a household where people are using marijuana, well, maybe are you going to be more likely to use? As it comes to like the opioid, the in utero exposures and opioids, for example, because of this intricate relationship between the opioid and cannabinoid system, the animal studies are showing that rodents that are exposed in utero have a higher predisposition to hit the lever for heroin once they're born. So it kind of primes the pump for addiction in general across the board. And it seems to be very unique to the endocannabinoid system. The other issue that I didn't have time to talk about, but given your background, I will bring it up. There's a lot of data showing that marijuana states have a higher incidence of autism spectrum disorders. And Susan Murphy from Duke has done some good animal studies on, because they always blame the mom, and it's not necessarily her problem. There's actually a lot of data showing that paternal use of cannabis does some, it kind of, I'll get a little sciencey, there's a methylation process of the genes that monitor autism, the autism genes. There's a methylation process by paternal use, which might increase the risk of having an autism spectrum disorder child. And Stuart Rees from Australia showed that marijuana states have a nearly 20% higher incidence of autism spectrum disorder. So it's a very complex space. And you bring up some very valid points. It's not black and white. It's not clear cut. There's a lot of nuances. There's a lot of variables we don't know. I think some of the ABCD study data does try to address some of the confounding factors like with alcohol use and other illicit substances, but you bring up a very good point of environmental situations. When it gets to psychosis, we don't, which is very, very complex, we didn't have time to talk about adverse childhood events that might be a factor. But there's a lot of data that show, there was a recent trial in California, if anybody heard about the young woman who was opioid naive. She took a hit off a bong and became acutely psychotic and stabbed her date 108 times with a knife. She had acute cannabis psychosis causing a murder. And it was the first one that I'm aware of in the country that's addressing cannabis-induced psychosis. And again, Eddie Ray Vauth, who shot and killed Chris Kyle, I know the Texas Ranger and the forensic psychologist that testified at the trial that he had cannabis psychosis. And I have example after example after example of these acts of violence and mass shootings and mass stabbings that are happening, that there's only one substance there. What's the causal relationship between the two? I can't really say, but you wonder. I mean, Christine Kirk was shot and killed by her husband in Denver in 2014 when he gobbled up a bunch of edibles and became acutely psychotic, and he's serving 30 years in prison. And I have his toxicology report. There was only one thing in his system. He became acutely psychotic from cannabis. I mean, to me, you don't have to get too deep to say, well, there's a temporal relationship between use, psychosis, and a violent act. There clearly is a causal relationship, but it's very, very complex, as you point out, and it's very tricky. But that's why I do what I do, because I cannot say for certain in certain instances whether it's a association, a strong correlation, or an actual causal relationship. But one of our authors, as I mentioned before, actually used the Bradford Hill criteria and was able to demonstrate the causal relationship between cannabis use and psychosis. And actually, cannabis is the #1 substance that has the highest conversion rate to psychosis. Nearly over 40% of people that use cannabis can convert to psychosis compared to alcohol, methamphetamine, cocaine, and other illicit substances. And I have all that data, and I'm more than happy to send you whatever you're interested in doing, but I think you bring up some very good points, and I appreciate that.
I do have a follow-on question.
Of course.
Earlier in the presentation, you showed some graphs that demonstrated what has been happening with overdose deaths with the various substances. And of course, opioid substances are probably top of the heap for that. My question actually has to do with Narcan. Is there any information about whether the availability of Narcan has actually removed the fear of death in opioid users who are seeking that very rapid, very peaked high, whereas previously, when they saw a lot of their friends and fellow users possibly dropping dead from seeking that high, and there was no recourse for treatment readily available, that they were more likely to seek treatment because of that fear. And is there any evidence that the availability of Narcan has somewhat removed that fear and has actually led to more overdoses because of even riskier behavior?
That's a very good point, and I'm going to answer that in two different ways. Number one, we have had a significant increased utilization of Narcan across the country. So the fact that our deaths are worsening under that banner is somewhat frightening to think about how many people would have died if Narcan was not available. I mean, I think our overdose problem will be 10 times worse than it is now. And there is some data on the number of lives saved by using Narcan that don't end up in that statistic of an overdose death. So I think the use of Narcan has been very important to try to dampen the number of overdoses. And I think I may have a paper, but I'll have to look in because I have so many. You bring up a very good point. They're training the librarians in the public library system to use Narcan. They're training teachers in schools to use Narcan. That's a very scary thing to think about. And so, yes, I think there are some, and some of the folks that I know in addiction medicine tell me, and although I don't have a peer-reviewed journal article on this, but my colleagues and friends in addiction medicine and psychiatry are telling me that people are saying, well, I'm more likely to get resuscitated because Narcan's more available. So I'm going to go to the library knowing that the librarian is trained in the use of Narcan. I'm going to go, in the Dewey Decimal System in the back and say, I'm going to be back there, so the librarian is more apt to resuscitate the overdosed person. So I think they are kind of pushing the limit in terms of their risk. And I think that you bring up another very good point, that it's not necessarily they're not as fearful of an overdose. They're saying, well, I'm more likely to be saved from Narcan, so I'll take the chance. So I think it's really a sad state of affairs that we're in, thinking about that.
Thank you. I'm looking across any other comments. Councilman Donaldson.
Yeah, thank you, Dr. Finn. I think your presentation, there's so many things you hit on in there, it almost numbs up your audience to where it's like you just kind of, your eyes, glaze over and you're like, any one of those things is shocking, but 25 of them in a row almost becomes overwhelming. But here's my question is, and I want you to answer it not from your opinion, but just from, this is what the studies I've looked at say is the outcome of this. This November, it looks like there's a good, well, if they gather enough signatures, recreational marijuana sales in Colorado Springs will be back on the ballot. What does the research say about a city adopting recreational sales versus medical sales as far as the adverse events and outcomes which you've described, like in detail? Does it make a difference? It's no different because there's recreational sales around us, or what does the data say, not what does the bin want to happen?
Right, well, two things. One is when I spoke to the state legislators in South Dakota about a year or so ago, one of the state legislators told me, thank you for the front seat to the horror show. And I took it as a compliment because they were going down this road, and I said, this is going to happen in your community. I don't care if you're going to do it, but you can't claim ignorance because the states of California, Washington, Oregon, and Colorado had what we described as unintended consequences. We didn't realize the potencies were going to go through the roof. We didn't realize, perhaps children were going to get poisoned, or we're going to have more marijuana-related driving fatalities, or healthcare utilization, or cannabinoid hyperemesis. People have died from cannabinoid hyperemesis. So I think it is drinking from a fire hose. There's a lot of points that can be covered, and there's more. I mean, I don't have time to get into all of it, but there's a lot more that is somewhat frightening from a public health and safety perspective. And again, the legal drugs we have now, we've not done a good job with. We've not done a good job with alcohol, tobacco, and opioids. They cause significant societal impacts and negative effects, and now we just have another addiction for profit industry that's is already doing the same thing. As an answer to your question, the data does show that states that legalize have problems. I just look at Portland, look at LA, look at San Francisco, look at Seattle. I would encourage you to look at some of the things like Denver in decay with the videos of what's happening when you have these progressive drug policies. If we go down that road, fine, but just buckle up. We're going to have problems, period. And the data is very clear on that. Look at Seattle is dying. There's a nice hour-long video on what's happening in Seattle. Look at all these other cities that have progressive drug policies that start with marijuana and then open the door for other things. Now we have the psychedelics. Now we have all these other substances that we're promoting. At what risk? We're in uncharted waters. It took us decades to figure out what happened with tobacco. Right? And now the current marijuana products have almost the same addiction rate, nearly 30%, as nicotine. And remember the trials, the tobacco trials, all the CEOs went down the line saying nicotine is not addictive, but we know it is. And they knew it was. And we're seeing, this is big tobacco 2.0. We're following the same playbook. We're tugging on the heartstrings of the public. We're promoting a substance that is potentially dangerous. Not everybody that has a beer is going to get in a car wreck. Not everybody who smokes a cigarette is going to get lung cancer. But we have to counsel our communities and provide the data saying, and I tell this to my patient, this is what you want to do. I'm not going to chastise you or judge you, but these are what's going to happen. These are the risks you have. For example, if I have a patient that has had several heart surgeries and is on blood thinners, that might not be the person that you may want to counsel them against using that. Or if they have a history of suicide attempt, major depressive disorder, etc., they may want to counsel them that this may not be good for you. But if you look at the data in other communities and cities that have brought recreational marijuana into their communities, things didn't go well. And they always say, well, it's going to fix our budgetary woes. But if you look at all the states that have had legalized or medical marijuana, it's less than 1% of their budget. A lot, even in Colorado, I think it's 0.8% of our state's budget. It's not a cash cow. Chicago ran into the same problem. Michigan ran into the same problem. California ran into the same problem. It's not fixing the problem. And then they backpedal. You know, everybody would agree that, you know, 10 years ago, like, tax the crap out of it, we'll make a lot of money and whatever. Now California is backpedaling. They're giving the legal marijuana tax breaks. So tax it and then not tax it. And that's one road that California went down. But I think if we go down this road, we have to be prepared and can't say, well, we didn't know this was going to happen, because it is going to happen. It's happened in every other city in the country that's gone down this road.
Thank you.
Dr. Booth.
Dr. Flynn, I don't have a question for you. I just want to say thank you.
Oh, you're welcome.
Okay, I'll display my ignorance a little bit. How many states have legalized the use of marijuana? And then do any of those states have a, what did you call it, a potency cap?
I believe there's about 38 states, and plus Washington, D.C., the last I checked. Vermont, I think, is the only state that I'm aware of that has a potency cap of 30%, but the industry is fighting it tooth and nail. Right now, it's still up in the air. And that's a recent development. I've worked with, again, with a lot of folks around the country, and I've been my finger on the pulse of what's happening in Vermont. They are pushing back on a potency cap. And I think from a public health and safety perspective, I feel the industry should be coming along for the ride. They need to support warning labels. I think we finally have pregnancy warning labels, but I have pictures of dispensaries that at the exit of the door, they have this green wallpaper with marijuana leaves and a little green sticker in very small font, don't use during pregnancy. You have to get right up to it. But I think you have to warn patients on the risk of psychosis with high potency products. You have to warn women not use during pregnancy. I think the industry should be culpable and should be proactive in this space. So it's not just public health job to do it. I think it needs to be hand in hand, especially if you're going down that road. You have to support warning labels. You have to prevent youth use, youth access. I mean, the loophole, I think Senate Bill 1317 a couple years ago was trying to prevent looping. I don't know if you're familiar with the term, but you can get your marijuana card and then go to dispensary A, B, C, and D, get your two grams at each place, and then you have 8 grams of marijuana in your trunk, and then you can become the school drug dealer. So I think it's really a multifactorial, very complex situation. I think we really have to, from my perspective, really protect the public health and safety with education, harm reduction, targeting kids, unfortunately, in elementary school. I mean, I do a lot of work in our schools in this community, and I can tell you our teachers are seeing 2nd and 3rd graders open their lunch pail with a used Maggie's Farm container in it with candy, but they can't confiscate. The SRO can't confiscate, even though they're highly suspicious that it's a edible. And then Johnny falls asleep and Susie falls asleep after lunch and doesn't learn anything. So talk to your colleagues in the schools. I mean, if you haven't already, I would encourage you to do so, because it's rampant. You know, and interestingly, I asked one of our local high schools, I said, what's your biggest problem in high school right now? Thinking it's going to be pot. It's mental health. We are in the middle of a mental health crisis right now, and it's complicated, it's complex. But the fact is that marijuana is always disregarded as a piece of the puzzle when it's a very large piece of the puzzle. It's not the only problem. Our mental health crisis is very complex, and it's front and center, especially in our youth today.
Well, Dr. Finn, thank you. I appreciate the time and the energy that you put into this subject. You obviously are very well learned on the subject, and you do that because you have a passion for it.
Not a career choice.
What's that?
Not a career choice.
No, but the passion that you show is because you care about people and you want to see good outcomes for not just your patients, but for our community as well. And we're grateful for that, grateful for the presentation, and thank you, and best of luck in your work.
Yes, sir. Thank you. Thank you all.
Okay, and Susan, that brings us to the director's report.
Sure. I just have a quick update that I want to, Dr. Bernadette Albanese to come down and circle back to address Commissioner Gonzalez's question earlier. Wanted to flag everyone, Board of Health members, to a May 15th meeting. I'm working with Commissioner Stan Vanderwerf, who is also a state Board of Health representative, and we are going to host a state Board of Health meeting in Colorado Springs. We are going to make a day of it with their official meeting, and then also trying to put together a tour of some aspect of Colorado Springs, time limited, but possibly the sports center, the Bill Hybel Center, possibly the Olympic Training Center, and then also end with a social. And so our executive staff will be invited, and wanted to invite you all as well. And more details will be available, but that will be on May 15th. And I know our president, Ted Colas, will be out of town, and I also will not be able to attend because my daughter will be graduating high school, but that still is going to happen. So circling back to Commissioner Gonzalez's question, if you remember it, Dr. Albanese, and about exotic diseases.
It's about historical diseases rather than exotic diseases. Yeah. Did you have anything else, Commissioner Director Whelan, that you wanted to cover for your report?
I do not.
Okay, all right. So yeah, I think this is a tale of historical diseases making a comeback. So I think you had mentioned pertussis and TB. So I think so pertussis is whooping cough. It's a vaccine preventable disease. We've had the vaccine for many, many, many years. It's a routine childhood vaccination. So I don't readily have data on whether there's something different in Colorado or El Paso now as opposed to in the past, but there's definitely been pockets of increase in pertussis cases around the country. I think the challenge with pertussis, so being vaccinated against pertussis is a good thing, and it does reduce your risk of getting infected, or if you do, sorry, I can't see everybody through the monitor, then if you do end up getting the disease despite being vaccinated, it will make it milder. And it's a good vaccine, but it's not a fabulous vaccine. It's one of those vaccines that it's a complicated bacterial germ, and so, but again, still provides ample protection to sort of keep things sort of in a low level overall. The other two diseases that I want you to mention, so TB is making a comeback, and I think this is, in Colorado, just because we have our TB program at the health department, we also, I also provide services for Adams County, and we contract with the Denver TB clinic, which takes care of TB for the whole metro area. They're getting inundated with new TB cases, and TB is still a significant worldwide problem. And thank you, Marcus. And countries without adequate infrastructure to manage TB, recognize it, get someone through treatment. Treatment for TB takes a long time. It takes 6 to 9 months, sometimes longer in some individuals with complicated medication. So it really is a hard disease to tackle. But we live in an international world right now. People move readily. And so when TB is broken in other countries, which it still is, particularly countries with very sort of under capacity public health infrastructure, we will get more cases in the United States just from international travel. And TB can stay quiet. TB infection can stay quiet in your body until it like wakes up and makes you sick. So that's another problem with TB. But I think We are going to be on a roller coaster, potentially related to the pandemic, post-pandemic, because people were not getting adequate screening and treatment for early TB infection, and then they just pop up with their TB illness a little bit later on. So, so that story is still evolving. But the other one, I think that's getting way too close to home is measles. So measles is a vaccine-preventable disease. The measles, mumps, rubella vaccine is an excellent vaccine. Vaccinated people rarely ever get breakthrough measles. Everybody knows what breakthrough is, right? You get vaccinated and you get disease anyway. It's a fabulous vaccine. And we have measles problem when people aren't getting vaccinated. That's it. That's the answer. That's the cause. That's the problem. And so I was pulling a little bit of data for the United States over the past few years. So measles was eliminated from the United States in 2000, meaning there wasn't in-country spread of measles. The only way that we would have measles is it comes in from an individual who might have been exposed to measles in another area that does have a lot of measles transmission, comes to the United States, gets sick, and then we potentially have their diagnosis here, and then we have an issue. So, so far, just for the first couple of months of 2024, we have 35 measles cases in 15 states around the country. That's a high number. Last year, in total, there were 58 cases, so we're more than half of that in 2 months of the year. In 2022, there were 121 cases. That was related to a large outbreak in Ohio that extended from 22 to 2023. That had 85 cases heavily in children that were unvaccinated. 95% of cases were occurring in children who had never received their MMR vaccine. And then in 2020, there were 13 cases, pandemic, everybody staying away from each other. And then the next big year was 2019, when there were 1,274 cases, almost all related to potentially someone getting exposed internationally. And these include US residents who are unvaccinated, going international to a country that has measles, getting exposed, getting back on the plane, coming back home, and then getting sick in the United States. And then if that is involved, if that case occurs in a community of unvaccinated persons, it will spread. And so of those 35 cases that have been occurring this year, right now, Broward County, Florida is a hotspot. And those cases, I think the latest I saw in the media, there's 10 cases. They're all school children, and they're all children who haven't been vaccinated. And that in that school district, there are low vaccination rates. And so measles vaccination rates, it doesn't take much to spread things around. So the recommendation is to have measles MMR vaccination rates up to 95% to keep things really suppressed, meaning most people will be vaccinated. So even if you have a case of measles that occurred, that person is only around vaccinated people. And so the virus doesn't hop and make someone else sick. In Florida, the measles, I think, again, I'm taking this from media reports, so I haven't verified this directly, but I'm hearing around 80-something%. You think that's not such a terrible number. Well, it's enough that if you introduce it into a closed environment like a school, and there's classrooms with, and those are averages, right? But say there's classrooms with kids that are even lower than that, and you stick a measles case in there, if you are not vaccinated against measles, meaning you're susceptible, right, and you're exposed, 90% of people are going to get measles. It spreads quickly, it spreads through the air, and it's easy to catch if you don't have immunity. So I just very, very quickly looked up some immunization rates for El Paso County. The state website is a little bit dated because I didn't expect this question, so I didn't have time. But back in 2020, on average, for toddlers in El Paso County, our measles vaccination rate was 84%. That's not, or 85.5%. That's not good. So, you know, we are worried. We had a measles case in the metro area back in December. It caused a multi-jurisdiction, multi-health department response, including El Paso County. Thankfully, we didn't have any secondary cases down here. The initial case was in Arapahoe County. But these investigations are huge, and we try, and we use actually vaccine to prevent more spread. So if we get a case, and there's people around that have been exposed that haven't received vaccine, we try to get vaccine into them as soon as possible to give them some immediate immunity. So The way you fix measles is vaccine. That's it. That's the way you fix risk for measles. And so I think we're going to have a rocket year if we already have, 35 cases in 2, and it doesn't sound like a lot, but these investigations can be huge. I can tell you, Broward County, the health department down there is probably working 7 days a week to try to figure out how to suppress this and how to get some folks vaccinated.
Thank you, Doctor. And one of my concerns is that, if you're reading the news, we're having a lot of people come from other countries that are moving into largely the Denver area. We have no idea if they've been vaccinated for whooping cough, if they've been, treated for TB or have TB and are moving from the southern border up to areas here. And it's a concern to me, and I'd just like to know if we're seeing any spikes, if we're not good. I don't want anything that's spread here, but I just wanted to kind of know if that's an indication, because I'm greatly concerned about what has been an influx of people coming from outside of the country that we know are in Denver. And as far as I've been told, I've not been told that we can confirm whether they've had public health checks or not. So thank you.
And I think Councilman Donaldson has a question.
Yeah, and it's really going to follow along the one that Commissioner Gonzalez was asking. And the Border Patrol numbers are approximately 9 million people have come across the border in the last 3 years. And I don't think they get much screening at all for their medical history, current illnesses when they cross. How does that strike you as a public health threat or concern for our state, our county, our country?
I think that it's a difficult question to answer, because there's, the social political situations from these countries where people are trying to leave is challenging, and so.
But I'm not asking about all that. I'm asking strictly from a medical, public health position of the United States, of this county, of the state. How does that strike you as a physician? Is that a wise policy?
I think it is. I think Denver, having also worked at Adams County Health Department, we have encouraged Denver County and Denver Department of Public Health and Environment to perform health screenings and provide vaccination, particularly for varicella, because actually there's been some chickenpox outbreaks going on. And they are actually in process of doing that now. So I think once they've had some opportunity to build some infrastructure, they are providing vaccine, and I can't confirm whether there's also MMR vaccine, but they are providing some vaccination. So it's a challenging circumstance. I mean, I think you just need to be acknowledge where we're at and be prepared to respond given the influx of individuals. But the measles situation, the outbreaks occurring internationally, just for your awareness, are actually in the European Union, Eastern Mediterranean, and parts of Asia, particularly Indonesia and India. And so for importations of measles, those are actually at the moment the countries of greatest concern, bringing risk. And so that would just be a visitor or relative or someone just coming to the United States, or someone from the United States traveling to those countries unvaccinated. So the best thing we can do in our country and in our county and in our state is to get people vaccinated with MMR. That's what we need to do for that disease, and any other vaccine preventable diseases. We have solutions to control some of these diseases, and if people want to stay healthy, that's their path forward, despite whatever might be visitors that may be coming into our state or into our county.
Agree on the MMR vaccine. I'd point out that Europe has also had millions of immigrants from third world countries, from Africa and other places, come into Europe over the last few years. And it's good that they do the screening in Denver. I mean, that's the minimum. But isn't that too late once someone has been in Texas for weeks and then transported through the country on buses? If they have TB, there's been a lot of exposure over that period of time, and other communicable diseases. We used to have a policy where you got to Ellis Island, you got screened, you got turned around, sent home if there was anything wrong. And that's what's supposed to happen at the embassies, is they screen people who want to come to the United States, versus what happens now is they get overwhelmed at the border and basically just let them in. So its danger is the policy we have now, where we transport people into the interior of the country and then we do the screenings weeks after they've crossed the border. Would you agree with that?
I would agree that can pose greater risk in some circumstances and in some locations.
Thank you.
Okay, I think we have a question from Dr. Chan.
I had a comment, but I think it's already been addressed. I guess I could reiterate the emphasis about measles. Measles is a very concerning disease because it's probably the most contagious disease in the world, and most people will survive measles, but it does have a suppressive effect on the immune system for years afterwards. I worked in international health, and whenever camps or refugee situations were set up, number one was water and sanitation. Number two was vaccination for measles, because it has deadly implications that are not just measles, that are not from the specific disease event itself. However, I don't think that there's any real need to be particularly terrified of unscreened or undocumented immigrants if the U.S. population, which has access to the vaccine, is adequately vaccinated. People already in the United States are not going to get sick if they avail themselves of the available vaccines. The individuals who come in who do get sick, it may tax the healthcare system to some degree if there's a lot of people being seen for measles, but for their outcomes, it's not going to be any different than what it was in their home country where they couldn't get vaccinated in the first place. I think that the bigger concern is, of course, TB. I have worked in areas where there were very, very high rates of TB. Some were associated with HIV/AIDS in some areas, and in some areas it was just endemic. But there's no scarier disease to me than multi-drug resistant TB. And that disease, I think, is probably more concerning when people are moving throughout the country prior to getting any kind of screening whatsoever. And it is true that our immigration system, when people come in through legal channels, is very good at screening people for these types of diseases that may present a public health threat. However, I do think that we need to really think seriously about some kind of program to mitigate these risks.
Thank you for your comments. I agree with you.
Thank you, Dr. Chan. Any other comments or questions for Dr. Albanese?
Just if I could, it's not even going to be a question, but just to point out, because there are non-medical folks who watch these meetings, there's media that watches it. Tell us about vaccines to prevent TB. There is no such thing. Can you just go into that? It's just a treatment after.
There is a vaccine for TB. It's called the BCG vaccine, and it's only used internationally, and it's used primarily to prevent. So it's it's used in children primarily to prevent the worst form of TB, which is TB infection of the nervous system. And our relative to countries that have a lot more TB than we do, we don't use it here in the United States. It's not indicated. So there is a vaccine with some effectiveness used in some countries with very high levels of TB. But for all practical purposes, it's not recognition of TB and TB treatment in adolescents and adults is really what's necessary to stay ahead of this.
But in the United States, there is not a vaccine for U.S. citizens to go and get and prevent TB. It's really, we screen it and treat it before people enter the country. That's the traditional way we've protected our population. Now we have essentially 9 million folks who've entered the country unscreened, and we don't know their status. And it is a risk for the U.S. population. And so it is different than other diseases where you can get a vaccine and you can protect yourself in the United States.
Yeah, that is correct. We don't have a vaccine. It's not a vaccine preventable disease in the United States. The one thing about TB, it's not a good disease. However, it's also very, very hard to catch. And so there isn't, unlike measles, where, well, if we were in, say, a smaller room and I had measles and I was in the room for a couple of hours with all of you, even some distance away, you could potentially be exposed just from me coughing or potentially releasing it into the air. TB is much, much, much harder to contract. It requires prolonged close contact over the course of many, many hours, if not days and weeks, before someone would be sufficiently exposed to have risk for infection. So that's it. So it's not to worry about. I can be walking through the grocery store and someone with undiagnosed TB walks by and I'm going to get exposed and infected. That's not the way it works. So just to finish the factual information about TB.
Just one final question then. If you were on an airplane or a bus and the person next to you was coughing and they had TB, do you think you'd be at risk of contracting TB?
Not on most regular, normal length flights. So like I said, it is pretty hard to catch. So even being on an airplane for whatever cross-country flight or something is unlikely to result in infection.
Thanks.
Thank you, Dr. Albanese, and appreciate that. Susan, you have more for your director's report?
No, I have a couple more things. Thank you, Dr. Albanese. Just to kind of circle back to some of the questions with Dr. Finn and MJ, I had wanted to double check about what we tested for with youth deaths, and I did want to confirm that our coroner's office tests for marijuana and youth deaths, and he has always done that, but it is also required by law, which is helpful for our coroner's office also to get reimbursed. So with the child fatality review team that Commissioner Bremer had mentioned, I just wanted to mention that our coroner's office do test for marijuana. And just on another note too, I mean, when we're talking about standardization as it relates to capping marijuana, I mean, there's no capping to my knowledge also of even nicotine and vape and the solution. So I mean, there's a lot of aspects to how easily available some of the drugs are used, and then there's no standardization based on, it's not required. And then I wanted to mention that we are working with the City of Colorado Springs and also generally with county and some other behavioral health partners to launch a behavioral health 360 platform, which will be a resource to decrease barriers for behavioral health resources. And so when we're talking about topics such as mental health, suicide, addiction, all of these different aspects. More to come on this, but our agency is trying to work on this platform, which has vetted over 20,000 different resources that are evidence-based to get easier access for residents in the behavioral health realm. So more to come on that, but I just wanted to mention those few things, and thank you.
Thank you very much. One thing I neglected to say earlier, we have an elected official with us, David Lineweber. Thank you for coming and spending your time with us. I should have pointed that out when you first walked in, but we were in the middle of things and I didn't do that. I'm going to entertain a motion to adjourn at this point.
So moved.
Thank you, Commissioner Bremer. Second? Was that you, Mayor? Thank you. And all in favor of adjournment, let it be known by saying aye.
Aye.
Aye. Any opposed? Thank you. This meeting is adjourned.